Okay, friends. In the next few minutes, I would like to talk on the elderly patient with the diabetes. This is a one case study. 86-year-old male, type 2 diabetes for 42 years. He is on sulfonylurea glycoside and metformin combination. Glycemic control was good. See, at 86 years he is, with 42 years of the diabetic life, the blood sugars are very good. That is possible, provided if you tell to the patient about the dietary approach, exercise and good medication, cessation of the smoking, moderation of the alcohol, ideal body weight. So these people, all the diabetes can live beyond 85. Okay. He had a fall following a slip at the home. That is very unfortunate in all elderly individuals. Fractured neck of the femur, very, very common. Underwent hemiarthroplasty, some Moore's arthrosis or something like that. So he didn't require insulin or OHA in the intraoperative period as he had recurrent hypoglycemia. Okay. His activities were restricted and food intake reduced. Later on, his blood glucose were found to be under control with half the dose that he required before. He is stable. So what advice would you give to him? Elderly diabetic. He is on dietary approach. Okay. What advice?
High protein diet.
No. He is getting hypoglycemia. See, hypoglycemia. He is reducing the doses of the drugs. So what drugs he is getting? So what drug to stop? That is the take home point. So in all the elderly individuals, when the sugars are good control, when he is getting the low sugars, so you blame the sulfonylureas and better to stop the sulfonylureas because this is a long acting sulfonylurea glycoside that acts for about 18 to 24 hours. If it gets the hypoglycemia, it will be prolonged hypoglycemia. See, always see that elderly individuals, when they are living alone or when they are living in the old age homes, it is very difficult to control the hypoglycemia. So always avoid the drugs which cause hypoglycemia in elderly individuals. So you stop glycoside, continue the metformin because it's stable. So what are the special problems? Presence of the other underlying comorbidities like likelihood of the polypharmacy and the drug interactions, possibility of long duration of the diabetes with attendant complications, impaired physical and cognitive functioning. Not all elderly patients with diabetes have these problems. Some people, most of the people have the cognitive dysfunctions, especially the people with post-COVID or more than 80 years, maybe the Alzheimer's or dementia, multilateral infarcts or some Parkinsonism. So all these things will be seen in most of the elderly individuals. What are the treatment targets? See, older adults who are functional, cognitively intact and have significant life expectancy should be treated using the goals developed for the younger adults. So these people treat as them they are young because they have the long life expectancy. They are good, their cognitive function is very intact and they are very functional. Glycemic goals can be relaxed and individualized for patients not meeting the above criteria. So when they are weak, when they are sitting alone, when they are not doing much work, so definitely the goals are reduced. De-intensification of the complex regimens is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved within the individualized A1C target. In all cases, complications like dehydration, delayed wound healing, and HSS should be avoided. So hyperglycemic, hyperosmolar state. Treatment of other severe risk factors should also be taken into the consideration. So in all elderly individuals, it is the diabetes and comorbidities. So they are not alone diabetes, they are hypertensives also with past history of IHD or CKD, etc. ADA consensus guidelines for the elderly patients. Take home point for the elderly individuals is, so don't use the sulfonylureas. Even if they use the sulfonylureas, it is only smallest dose of the sulfonylurea. Use the metformin and respect the kidney function. So when the elderly individuals, when the creatinine level is more than the 1.5, the 2, again better to reduce the dose of the metformin or stop. Pioglitazone, avoid in elderly women because the postmenopausal women, the chances of osteoporosis are very high. So this pioglitazone will cause osteoporosis. And gliptins, they are good in elderly individuals. SGLT inhibitors, they are good in the elderly individuals, but again respect the kidney function. So when the GFR is less than 25 or less than the 30, so better to stop the SGLT inhibitors also. Insulin, good in elderly individuals, but use the dosages which does not cause hypoglycemia. So use the long-acting insulins, basal insulins, which won't cause the hypoglycemia. So give 10 units or 20 units or 30 units of Lantus at the bedtime. That will be the sufficient for most of the elderly individuals. So that's how we have to treat in elderly individuals. Again, if the patient is having the other comorbidities, suppose hypertension and the diabetes, so there is a role of the ACE inhibitors or ARBs. Again, when you are using the ACE inhibitors or ARB in elderly individuals, you respect the potassium levels. So when the fellow is having the hyperkalemia, so again better not to use the ACE inhibitors or ARBs. An intractable cough, that could be a reason for the ACE or ARBs, or sometimes elderly people also, because of the chronic smokers, so they may also have the cough, chronic cough. So it divide, the cough is because of the smoking induced or ACE inhibitors or ARBs. Okay, so these are the things you should think of it. The statins. So we all say statins are very, very good, very good. But when you want to initiate the statins, better not to initiate beyond 80 years of age group, because the statins are not like an antibiotics. So you should have a long expectancy, long life expectancy to use the statins. So at the age of 25 years, 30 years, 40 years, 50 years, diabetic, hypertensive. So always statins are needed to have reduced atherosclerosis. But in 80 plus individuals, to initiate the statins, not of much use. Again, the aspirin, if you want to use it as the primary prevention, always dangerous in the elderly individuals, because intracellular hemorrhages are very common in elderly individuals when you use the aspirin as a primary prevention. So no history of IHD, no history of CVA, no history of TIA in 80 plus, very young fellow, very active fellow. So don't introduce the aspirin, because for the fear of intracellular hemorrhage. Suppose a past history of IHD, past history of CVA, so you have to use the aspirin. Again, when the fellows severe gastritis are having the polypharmacy, so then there may be the aspirin resistance or aspirin insensitivity, then you can go for the clopidogrel in such individuals. So these are the common drugs we often use in elderly individuals. Again, for all the elderly, you need not prescribe a B complex. Not needed unless they have multiple comorbidities. So vitamin C, so good for sometimes. Zinc is very good. Vitamin E is good. And then the calcium is very, very good for all the women. So these are the very important. Again, even the calcium, don't give 250 milligrams or 200. At least they need 1000 milligrams a day. At least 500 milligrams a day. So that is very, very important, calcium. Okay. So that's how in elderly individuals we have to treat the diabetes. So I told you something about the sulfonylureas in elderly, metformin in elderly, respect the kidney function, pioglitazone don't use, alpha glucosidase inhibitors. So you have to give before the food. So maybe O-glucose 0.2 units or 0.3 units just before the lunch or the dinner, you can give the O-glucose in elderly individuals. And if the elderly individuals are having the nausea, vomiting, etc., better not to use these drugs, because they promote the gastrointestinal side effects. And then the gliptins you can safely use. And when the creatinine levels are very much elevated, so better to use the linagliptin, because you need not change the dosages. So in elderly individuals, suppose the patient is getting the sitagliptin, when the creatinine level is the 2, you should reduce the dose of the sitagliptin according to the creatinine levels. So if you don't want to reduce the dosages, etc., then change out to the linagliptin. And linagliptin can be used without changing the dosages, whatever may be your kidney functions. So these are the few fundamental differences and fundamental points one should take care while dealing with diabetes in elderly individuals.